Hey, welcome to ACC 2026, and I'm joined by my good friend Ajay Kirtane. Welcome, Ajay.
How's it
And
going?
Bill Fearon. Guys, I've been involved with QCA since the beginning, and it was always my dream to be able to use QCA along with measurements of blood flow to do computational dynamics to make all these measurements. And now you guys are comparing a QCA approach to looking at flow with a pressure wire approach. So talk to me about the background and what you did and what you found.
Yeah, thanks, Mike. And I think the key thing is we know that physiology in the cath lab is class 1A, multiple randomized trials, all New England Journal, and yet it's just grossly underutilized. People don't use it as much as perhaps they should. And some of it has to do with believability, but I think a lot has to do with the fact that putting up a guide and putting down a wire and equalizing and giving adenosine and going through all those steps is a bit of a pain. Yes, there's a little bit of feeling that I know whether the lesion needs to be treated or not, but I think a lot of it has to do with the workflow. And so the ability to do it potentially offline or do it in the lab without having to manipulate, but yet do it fast is something that we now have using computational science. And you can do it a variety of ways. But in this trial, we studied the CathWorks system, which is basically a resistance flow model. And what we wanted to do, though, and Bill and I have been talking about this for a long time, is we need randomized data showing it's as good as a wire. Because we could say it's as good as a wire, we could feel it's as good as a wire, but if we don't prove that it's as good as a wire, then you're kind of left a little bit wanting. And so that was exactly what we did in designing the study, was to show in 1924 patients, could this be as good as a wire? So maybe, Bill, you don't want to tell us a little bit what we found?
Yeah, so thanks, Ajay, and thanks, Mike, for having us. So this was a large multi-center trial, 59 sites from US, Europe, Israel, and Japan. And we included 1,930 patients, and they were randomized one-to-one to either pressure wire guided treatment, where they measured either FFR or a non-hyperemic pressure ratio, and then treated the lesion, depending on what that showed, or to FFR angio using angiography derived physiology. And again, treated patients with PCI or deferral. And these were your typical patients. Average age was around 68, 40% diabetic. Typical risk factors, about 10% were ACS patients, and the rest were stable. Um, about half the lesions were LAD, and the other half were right coronary or circumflex. And some of the key findings that we found were, first, the procedure was shorter with the FFR angio approach, including the physiologic assessment. In addition,
And how
fluoroscopy.
much shorter, because it's like dog years.
Yeah,
1 minute for, an interventional cardiologist feels like 7 minutes. So how much time did you shave off?
yeah. So, well, the overall procedural time was 39 minutes median in the FFR angio arm and 42 in the pressure wire arm. And the assessment itself was 6 minutes on median and versus 8 minutes. Um, Also, there was
So again,
less.
So three
faster,
minutes,
faster.
that's 21 minutes faster in the interventional cardiologist's mind.
Right.
Yeah. Yeah.
Yeah, and there was less contrast volume given and also less fluoroscopy time, which I think is relevant too. And then the primary endpoint of the study was the 1 year rate of death, MI, or clinically indicated revascularization. And that occurred in 7.1% of the pressure wire and 6.9% of FFR angio. And so the p-value for non-inferiority was highly significant, 0.0008. The upper bound of the confidence interval was 2.1%, which was well below the 3.5% pre-specified margin. And the individual components were all similar, similar death rate. MI was actually 2.5% in the pressure wire and 1.6 in FFR angio, and unplanned revascularization 4.6 with pressure wire and 4.1% with FFR angio. So really very reassuring results that we have, essentially identical outcomes with the FFR angio approach.
What was the concordance between the two approaches? Were there some lesions where you didn't intervene, where you may have with the pressure wire? I mean, was there a systematic undertreatment with angio or overtreatment? What happened there?
It's a great question, Mike. And I think that it's something that we're going to be looking at later because we actually do have the angiograms from the pressure wire group, and we can then analyze them and see what the actual concordance was. There was a slightly greater rate of PCI in the patients treated with FFR angio. But what's interesting is that the baseline physiology was slightly in favor, or slightly worse in that arm. And so it might just be play of chance. We don't know. The good news, though, is that from every study, and I know you've been teaching this from the beginning, any study where you do more PCI, you typically have worse outcomes. And in this study, we actually didn't observe that. So I think a lot of this has to do with somewhat play of chance. And again, this is within a margin of 8 or 9% overall. So it's not like you were doing too many PCIs. And remember, despite the fact that there were more PCIs done slightly, the procedure times were actually still lower overall in aggregate when you did it with the angio-based approach using software.
Wow. The use of FFR in the setting of ACS has had a little bit of a checkered history. I mean, often you're not dealing with, sometimes you are, but often you're not dealing with a very tight lesion, more of a complex lesion. I've always been a little concerned that the angio, in doing the modeling you're doing, may not pick up that thrombus in the artery, but maybe the wire would pick up some clot there that's diminishing flow. Did you see consistent results in the ACS population as well?
Yes, yeah, we did. When we looked at the subgroups, they're fairly consistent across all subgroups, ACS for sure. There were some trends, I guess we could call it, with LAD versus non-LAD, where actually in the LAD lesions, the FFR angio tended to have lower event rates than the pressure wire. And the other sort of interaction, I guess, was the patients who were randomized to pressure wire, the operator ahead of time declared whether they were going to do FFR or a non-hyperemic pressure ratio like IFR. And there was an interaction there too, where it turned out that the FFR angio arms differed in the two strata, but the outcomes in the FFR or the non-hyperemic pressure ratio arms were similar. So again, this was probably just play of chance. But overall, I would say the subgroups were very similar, across age and diabetes and bifurcation lesions and ACS.
Oh, Mike, to your point about ACS, I mean, I think, obviously the culprit lesion is one thing, but non-culprit lesions would be ripe for study. There are some trials that have been looking at this. And in fact, in the FIRE trial, they did use some angiographic FFR. But what we feel is pretty important is to say, can you look at the non-culprit lesions with this technology and can you validate it clinically? And maybe that's going to be a source for a future study. But, I guess the bottom line take home here is that you and me are alike. We want to move fast in the cath lab. We don't want to give heparin and put guides up just to do a diagnostic procedure. And so the ability to be able to do this in the lab faster than conventional methods without any procedural manipulation is a good thing. And we just now have shown that clinically there's not only no price to pay for it, but this seems like it ought to be a preferred way. So that would be my take home from it. I think it's a good thing to be able to do more guidelines-based practice, especially when it saves you time and workflow.
The LAD and the other arteries, the LAD is a different animal, say, than the right. I mean, you have a high pressure system, thick wall, so I'm not surprised that there may be some differences in the vascular beds. Well, I got to thank you too. My dreams are coming true. I got all the way to like flow dynamics and blood flow modeling and the frame count. I didn't do the FFR piece, but you guys have taken it to the next level. And it just goes to show you if you're a careful observer of an angiogram and take all the information we've been collecting for decades now, you can use it all along with AI and computational physics and modeling and get some useful clinical information to guide practice. And sounds like it's a great tool. Well, thank you too. Thanks for joining me.
Thanks, Mike. And it's good, always good to make you happy. I mean, you pioneered this space, so seeing it come this way, I'm sure it's amazing for you, and certainly because you trained me, it's kind of fulfilling that way as well. So thanks for that.
Yeah, and all those CTs these days, they're still, they're using the frame count to measure blood flow. They know the length and they know the time. That's how you get velocity. So, one person criticized one of our papers, Ajay, in the past. They said, well, you haven't validated it against the Doppler velocity wire. And you may recall I cited Newton's Principia that, distance divided by time is velocity. So, sometimes we over-engineer things. So it was my greatest comment to reviewer too ever citing Newton's Principia. So, all right. Well, you guys are killing it. Your generation is doing such a great job. Keep up the great work.